this new multi-site electrical stimulation device. So I'm talking about the Exopulse Molly suit. This is a full-body electrostimulation suit. It is constituted of a vest and a pant. It has 58 embedded electrodes that will help us stimulate about 40 muscle groups of the body. This is done through a control unit, which is here, and it's can be programmed specifically for the needs of each patient if need be, or it can run a protocol that is preset for pain, for example. It's a home-based therapy with simple-to-use on-off play buttons. They switch the on button, they see a 60-minute display on the screen, they switch it on, and then they watch it go down to 0, and when it's done, that's it. It's the end of the stimulation. And it has to be worn for 1 hour every other day for spasticity results. For pain, we decided to make them wear it on a daily basis, as it works much better because the pain does not last as long. The effect of pain does not last as long as the effect of spasticity. It was shown to reduce spasticity and facilitates muscle activation. And it was shown also to reduce nociceptive pain and enhance the quality of life. This is the program. So as you can tell, we can personalize it to the patient by adding the stimulation in certain muscles or decreasing them as need be. So there is a lot of research ongoing now for the Exopulse Molly suit, and it's being done in France at the Henri Mondor Hospital, where all of the studies listed are being carried. It's also being run in Germany, among other places, and in the UAE, where I'm in charge of the studies there. We also have right now 5 ongoing clinical trials, and the research has been going up, and the publications as well in the past few years, and expect a flurry of publication between the end of 2024 and the beginning of 2025. So I'm going to now present data of 2 clinical studies, Exocet, which is the use for multiple sclerosis, and Exostroke, the use in stroke. And as you know, spasticity is a common and debilitating symptom that is encountered in patients that suffer from multiple sclerosis or stroke. It can impair the patient's balance, and by doing so, it will impair their mobility, and it will definitely affect their quality of life. So the therapeutic strategies available to treat spasticity and its associated symptoms are usually limited in their efficacy and carry quite a few side effects. Therefore, any non-invasive stimulation technique may be very useful for the treatment of these patients and will render their life much better. So we came up with this study. It's a cross-controlled, double placebo, double-blind study that will be constituted of 2 phases. In the first phase, what we do is we evaluate the patient, and if they are eligible, we include them in the study. And then they will have 2 stimulations that will be separated by a washout period of 2 weeks. So the first stimulation they get, and then they rest for 2 weeks, and then they get another stimulation, and then they rest for another 2 weeks. And then we may enroll them in the second phase of the study, which is an open label phase where they take the suit home and they use it at home in an active mode so that they get the benefit. And we will do recordings prior to each session, at the end of each session, and prior to the open label, and at the end of the open label. So we are blinded. We don't know which session the patients are getting first, the active or the sham, and the patients are blinded as well. And we maintain the blind by asking the patient if they know which session they got, and then most of them do not. So the blind is really working well. So this is phase 1. As I told you, the assessment is done prior to the first stimulation, at the end of the first stimulation, then 2 weeks interval washout, and 2 weeks interval washout between the first and the second stimulation. And then we go into the phase 2, which is the open label study. What we are looking at is the primary endpoint is the Berg balance scale, which has been validated for measurement of balance. And we looked also at the number of secondary endpoints, including the pain, using the visual analog scale, very easy to use and at the same time very validated and very accurate. So the patient will have to cross the line where they feel their pain is, going from 0, which is the least pain, to 10, which is the most pain. Fatigue, using the same kind of scale, but for fatigue. Mobility with the time up and go, and then the multiple sclerosing walking scale, and then the falls efficacy international scale, and the spasticity modified Ashworth scale, and the VAS for spasticity as well, in addition to a quality of life. And we've used the multiple sclerosis international quality of life questionnaire, which has been validated in all the languages that we're using it in. Now, for the stroke study, we are again using the Berg balance as the primary outcome, and we are looking at all the secondary outcome outlined here for you. So we're again using VAS for pain, fatigue, and spasticity, and we are using the turned up and go and the falls efficacy scale for mobility, and the Euroqual 5 test for quality of life. These are our admission, inclusion, and exclusion criteria. For stroke, we've used patients that have adults between 18 to 75 years of age, but they are still being able to walk, so they must have a modified ranking score of 4 or less, having spasticity with a score of at least 1 on the modified Ashworth. And they would have had to have had their stroke at least 3 months prior to the admission. For Exocet, again, we're dealing with adults and an EDSS score less than 7, so we require that these patients are still able to walk, even if they were to use a walker or a cane to do so. And they must have a Berg balance score of 46 or less, which is associated with a tendency to fall. And we did not include in the study any patient for whom wearing the suit would present a risk. So these studies are being run in parallel in Henri Mondor in France and in Abu Dhabi, in Sheikh Shakhbout Medical City. We started a little bit later at Shakhbout, which explains why we have a little bit less recruitment. So Henri Mondor is ahead of us. They have 27 patients that have completed phases 1 and 2 and 4 in process, whereas we have 13 that have completed phases 1 and 2 and 11 in process for the multiple sclerosis study. And for the exostroke, the numbers are as listed for your review. Unfortunately, since the studies are not over and done yet, and we did not want to break the blind, I cannot present data from phase 1, but I can present to you data from phase 2, because this would not be breaking the blind. And this is what you have for Exocet. This is the Berg balance before the open label, before the open phase, and at the end of the open phase. And you see from the graph that the trend is always going up. So I'm sure we'll end up with a study which has very positive results. And here is the summary for the exostroke data from France as well, which shows you again Berg pre-open and post-open, and again the trend is for positivity. And this is the data also for the Berg in our studies in Abu Dhabi, which shows the same trend towards a very positive result, hopefully at the end of the study. Now, I would like to show you a couple of videos to illustrate what was going on. And this is a patient with MS that had, this is the before the simulation, this is after the simulation of 1 hour, and this is 1 month later. And notice how much faster the patient is 1 month after stimulation, and she does not need to use any walking aids anymore, and she does much better with an increased step, improved balance, and increased length and velocity of her gait. I want to show you the second patient here. This is again an MS patient from Henri Mondor. And in this one, there is a clear improvement that follows even after 1 session, in which you can tell that she's faster, more balanced, more steady, and she does not use the aids anymore. And this effect is much amplified at 1 month. The movements are smoother and they are much faster. And this is one more patient from France in which the speed did not improve, but we have an improvement of the pendulum and much smoother movement, as you can tell. Notice here she was about to fall, whereas she's very steady at the end after the simulation. I also would like to show you some data on upper extremity. This is a jeweler, and she came to us. She wasn't even able to drink from a cup initially, and then she wasn't even to ride, even holding her hand before stimulation. After 1 hour stimulation, notice the difference. She was able to start writing even 30 minutes into the stimulation, and she showed you the improvement on upper extremity as well as what I showed you before, lower extremity balance and gait. These are a couple of patients with stroke, and this is before stimulation and after 1 hour of stimulation, where you see a clear improvement in speed, an improvement in the hip flexion, and a decrease in the upper extremity tremor, as you can tell. And this is another patient with stroke. And I think the videos are pretty self-explanatory, but you can tell that there is an increased velocity, a clear improvement in speed. The hip flexion is better, the step length is better, and the upper limb obviously needs longer stimulation period for it to start showing. So how do you think this works? Well, when a muscle is stretched, there is sensory nerve impulse of the muscle spindle that are carried by the afferent nerve fibers. Those are usually the large diameter sensory fibers or the 1A afferents, and they are in direct contact with the motor neurons of the spinal cord. This will induce impulses in the efferent nerve fibers that will activate the muscle in question and that will cause a reflex muscle contraction called the stretch reflex. In parallel, there is sensory influx. If we are, for example, flexing the elbow, we will have to inhibit the antagonist muscle for it to work. So when I'm stretching the biceps, the triceps will need to be inhibited for the elbow to be able to bend. And so by activating the spinal interneurons in the same spinal segment, by the mechanism of reciprocal inhibition, if the biceps is stiff, if I activate the triceps, I will get the limb to relax. And this is what is called reciprocal inhibition. So the modulation of this mechanism can help reduce the spasticity in agonist muscles, and this will follow stimulation of the antagonist muscle, or by that I mean the afferent fibers, and it will activate the inhibitory interneurons that will subsequently reduce the excitability of the motor neurons of the spastic muscles. So electrical stimulation applied to the antagonist triceps will help reduce the spasticity of the agonist muscle. So in the case of the triceps, it will reduce the spasticity of the biceps, as I've told you before. And we can use a similar approach that we can apply to any muscle in the body. And by this mechanism, we can stimulate the antagonist to release the spasticity of the agonist muscle. And we can do that, as I told you, because we can modify the amount of stimulation we give. We don't need to give the same stimulation to all the muscle. We can program and make it very individualized for the patient according to their clinical exam and according to what they have, or we can use the preset programs that we have available as well for a condition. For example, we have a program for multiple sclerosis, one for cerebral palsy, one for stroke. If the hemi is on one side or the other, we can use the programs already set or individualize them if need be. So basically, we are going to have a cumulative effect on the spinal cord pathways, which are the proprioceptive pathways, and the reciprocal inhibition mechanism that will result in an improved gait. And by so doing, we will improve the gait and the balance of the patient by altering the pyramidal tracts and altering the spasticity. And all of this is going to lead to an improved gait, an improved mobility, as you saw, and also an improved function of the upper extremity. And of course, when you get that, you expect the patients to be feeling better, less depressed, less anxious, and to have a better quality of life. So I just want to talk to you briefly. I know this is a meeting for MS, but I have fascinating data to share with you about fibromyalgia, where we are finished with the study in France, and they just got the paper accepted last week for publication in the European Journal of Pain with some tremendous results. So fibromyalgia, as you know, is one of the most common chronic pain syndromes, and it affects 10 million people in the US alone, with 3 to 6% of the world population being affected, and a significant increase in the world prevalence has been observed over the past couple of years. Fibromyalgia is characterized by chronic diffuse musculoskeletal pain and other symptoms, including insomnia, fatigue, cognitive and mood symptoms that will impact the quality of life of these patients. The pathophysiology of this disease is not fully elucidated, and it has a complicated multidisciplinary management with different pharmacological approaches that have been tried, with often modest benefits and numerous side effects. So the suit here was welcomed as an addition to these patients. So we did not take them off of the medication they were taking, but we added the suit as an extra modality of treatment, and we have gotten incredible results. The clinical global improvement, as you can tell, 79% of the patients said that they felt much improved, with about 15% claiming no change, and only 6% thought that they worsened. The significant improvement in almost all quality of life aspect was seen in physical functioning, role limitation due to physical health, role limitation due to emotional health, emotional well-being, energy, social functioning, health change, and pain. All of these factors were improved in the study. So in conclusion, this suit offers analgesic and anti-fatigue effects in the context of a debilitating and difficult to manage disease such as fibromyalgia. The effects are accompanied by a reduction in the impact of the disease and an improvement in quality of life after phase 1. And additional results obtained in phase 2 suggested an improvement of the affective symptoms and the catastrophic pain-related thoughts that were seen in these patients. So we have an analgesic effect, which is similar to ones that we had found in an open label phase that I had run in patients in Australia, in which we had just measured the VAS pain. And this is what pre-stimulation, this is 1 hour after stimulation, and this is 24 hours later. So the effect was still there, but it was starting to wear off, which is why in pain, we've decided to make the patient wear the suit every day and not every other day, as we had elected to do for spasticity, because in spasticity, the effect would carry over until the next day at least. So very consistent results across the studies. This is where I'm going to end, and I would be happy to entertain any questions you might have, and I would invite you after the session to go visit our booth, which is just there, just before the food station on my right-hand side, on your left-hand side. Thank you very much for your attention.